name's Zoe, and I'm a speech and language therapist. So I'm going to talk to you a little bit today about my career, and just to give you a bit of an idea about what happens in the day of a life of me. I'm currently in a split post, so I work 3 days a week within the community. This is general community, can basically cover any diagnoses, anything that may result in someone having a communication or swallowing difficulty. And then the other 2 days of the week, I do general medicine. So again, covering the wards in a general hospital for a couple of days a week. So as a speech and language therapist, I work with patients who have communication difficulties and also swallowing difficulties. And you can see from the current slide, I've just put in a picture that I thought I'd share with you all. So this was from an allied healthcare professional day where we were trying to advertise speech and language therapy as a kind of career and get people to know a little bit more about what we do. And I am making mocktails on the ward for some patients with swallowing difficulties. So this was really good because we got patients who were on modified diets and fluids due to swallowing difficulties involved in making kind of these different mocktails which had different names, just to help kind of raise awareness about speech and language therapy and to get patients involved with kind of making drinks for themselves. So I've tried to include a little bit about the day in the life of me as a speech and language therapist. And I think every day is really different, which is one of the things that I love about the job. So I've kind of just given you a little bit of a taster about what you might expect with my day. So on my community days, I start at 8 o'clock, and first of all I'd be checking the shared email address to see whether we've had any new referrals come in. So we have different people that might refer to us in the community, so that might include like the GP. We have also trained other people, like other multidisciplinary team members, to refer into our service after we've given them training. So you might get it from like a pharmacist or for a physiotherapist, and they'll always detail, or they should always detail, what the reason for referral is, so that then we can triage the referrals appropriately, so we can then work out what patients we need to see more urgently. So for example, giving them a 1 week estimated or target plan to see them, and what patients can wait longer. So they might have a target date of up to kind of 8 weeks. So an example of somebody we might prioritize is somebody who has had a choking incident which has resulted in hospital attendance, for example. And somebody who might have a longer kind of wait list of up to 8 weeks might be somebody with chronic communication difficulties who might have had some speech and language therapy in the past, has had these difficulties long standing, but would just like a little bit more support of it from us. Next, I would start to see my patients. So often I like to start quite early, so I might start this at about 9 o'clock. And in the community, our patients can be outpatients, so patients that come into hospital, into one of our clinic rooms to see us. So these might be patients that are mobile and are able to access coming into hospital for appointments. We also see patients in their home for those patients that aren't able to come into hospital, as well as care homes as well. So an example of the patient, for example, I've seen at 9 a.m. is a patient with dysfluency, or you might know it as stammering. So I currently take on the dysfluency caseload, kind of assessing and giving advice and therapy to patients who might be struggling due to a stammer. Some of these patients might have had a developmental stammer from when they were younger, and now they're an adult, they want some more support with it. Quite often they're having difficulty kind of applying for jobs and things like that. Or it might be a patient with an acquired stammer, so they might have developed a stammer later on in their life, maybe as a result of something neurological. So you can get kind of a stammer post-stroke, for example. Next in my day, I might be going on a home visit. So I might be doing some communication therapy, for example, for somebody who's had a stroke. So there's lots of different communication therapies that you can do with patients. And it kind of depends on what the goal is. So it's all around setting goals with the patient and their family members, and trying to work out what you're going to work on in therapy and what's appropriate. Some communication difficulties someone might have post-stroke might be something called aphasia. aphasia, where they have difficulty with their understanding and their expressive language. They might have something called apraxia, where they might have difficulties with their coordination of their speech sounds, or they might have something called dysarthria, which is the kind of way their speech is produced, the way it sounds, how clear it is. Yep. So then next, move on to another home visit. So, for example, seeing a patient who has Parkinson's and reviewing their swallowing. So things I might suggest is I might go and see them have their breakfast or their lunch, or mid-morning in this case, and I might see them with a range of different food textures and give advice about what kind of texture food I think would be most appropriate for them to have. We're always thinking about what we can do to make the patient as safe as possible. So we're often thinking about what ways we can reduce the risk of food and drink going down the wrong way. If food and drink goes down the wrong way, this can cause chest infections, which can make our patients really poorly, and patients can also have choking episodes. So with our swallowing reviews, we're kind of giving advice and strategies to help reduce those risks. Next, I might go to a care home to visit a patient with motor neuron disease. So often with patients with motor neuron disease, we can have quite a lot of input around kind of communication and swallowing due to the kind of deteriorating nature of motor neuron disease. It might include things like voice banking, so banking somebody's voice so that they can use that voice later down the line when their speech might not be very as clear. And yeah, again, swallowing inputs are kind of monitoring how they're getting on with their swallowing, whether any modifications need to be made to keep them safe, or as safe as possible. Then in the afternoon, I would do my notes from the morning, write reports. So after we see every person, if we've made any changes in terms of what we're recommending for them to have, or if we need to write up like an assessment we've done, then we'll always send a report to the patient and the GP. And then I also be involved in kind of multidisciplinary team meetings. So for example, palliative care, MDT. So this is where you kind of have a representative from lots of different professionals who come together. We talk about patients that are on our list, so maybe different problems that have cropped up that week, and kind of using different MDT members' expertise in order to ensure that patient's given the kind of best possible care by us all working together to kind of problem solve. So it might include kind of doing, acknowledging that it would be good to do a joint visit together, or problem solving difficulties, for example, trying to do a referral for somebody to trying to do a referral to a professional to help with kind of training a family member on the use of equipment, for example. And then towards the end of the day, I'd be booking in patients for, I've put next day there, but maybe next week. It depends how organised I am. But yeah, booking patients in for the following kind of week or so. And yeah, finishing off all the admin. Might also include kind of doing referrals to other services, might need to give like the GP a call to discuss a patient you've seen that day. Obviously out in community, you don't have the benefit of having like an acute team around you all the time. So there's a lot of kind of admin side of things where you're doing a lot of, you'll have a lot of conversations with kind of different healthcare professionals after you've seen a patient. And then acute, so a little bit different than my community days, but it's a lot less planned and a lot more unpredictable. So the acute setting can go from being really, really busy some days to just relatively busy some days, always fairly busy, but you often don't know kind of how busy it's going to be until you get in that morning. So on an acute day, we come in and as a team, we look at the new referrals that have come through our system since the day before. So the wards will often send the referrals, like the doctors, giving a reason as to why they want us to see a patient. And then similarly to community, we then triage those referrals. So we look at what patients are a priority and need to be seen that day, and then what patients are able to wait if we don't have capacity to see them that day. Factors we might be thinking about, for, particularly for our swallow patients, as in the acute on the general medicine wards, it's mainly quite swallow heavy patients that we see rather than communication, we're always thinking about whether that patient has a route of nutrition. So sometimes if a patient is really unwell, the medical team are concerned that food and drink's going down the wrong way and they've got a bad chest infection, the medical team might place them nil by mouth, so they're not allowed to have any food or drink orally due to that risk of the food and drink going down the wrong way. So then when we're prioritizing the referrals, we'll be thinking about, if that patient is nil by mouth, have they got a route of nutrition, like have they got a tube in their nose, so an NG tube to help with nutrition and hydration, and if they haven't, then obviously they're going to be a priority for us, because that patient has got no means to have any nutrition and hydration until we come and give a speech therapy assessment. So in the acute setting, we see a range of different conditions. So I've just kind of given an example of a couple that we might see. So, for example, someone might come in with MS, multiple sclerosis. You might have someone who comes in with something that you wouldn't think like directly relates to swallowing, but it might be that they come in and they're poorly and it's knocked off their swallowing, which they were kind of, getting along okay with in the community, but now they're unwell. It's kind of tipped them off that baseline. So, for example, someone come in with a history of alcohol excess, they might have come in with a seizure, which has impacted, factors such as alertness, which has then impacted their swallowing. Things like head injury, so that might be that someone's fallen over, they've hit their head, and now they're needing support with their communication, because they might have communication difficulties following that, as well as with their swallowing as well. We sometimes support with capacity assessments in the acute setting. So often if a patient has communication difficulties, and for example they might be trying to self-discharge, we might support the medical team to complete a capacity assessment to see whether that patient can fully weigh up the risks of discharging themselves from hospital. Obviously everybody is if you've got capacity, it's in your right to make an unwise decision, even if it's against kind of healthcare professionals advice. However, if a patient doesn't have capacity, so for example they're confused, they're not understanding the information, then we have to kind of make that decision within their best interest, because they lack capacity to make that decision themselves. We're also involved on intensive care. So we might work with patients, for example, who have a tracheostomy, so they might have a breathing tube. We see a lot of patients that have dementia. And then at lunchtime, we always triage again, because during the day, more referrals might have come in. So even though we've made a bit of a plan in the morning about who we're going to see and who we're going to prioritise, as those new referrals come in, we might need to amend our priority list depending on the priority of the new referrals. And I've spoken a lot about kind of clinical like my day clinically, but there's also kind of non-clinical roles as well. So for example, continued professional development or training. So it might be delivering this. So sometimes we deliver training to, for example, healthcare professionals on the wards about how they can support patients with swallowing difficulties, or it might be attending training for ourselves. So for example, attending a training about pain management or other kind of aspects that will help us in order to fulfill our job on the wards. Also have a job role as supporting kind of more junior staff. So that might be more junior staff who are trying to achieve competencies, for example, their swallowing competencies, which I might support them with, and also they might come and shadow, for example, or we might have students who are coming to shadow or to work alongside us as well, so supporting other people as well.